online. So hi everyone, I'm Sandra. I'm the CEO of the Neighbourhood Pharmacy Association. Thank you so much for joining us today for our In the Know webinar, the Post-Pandemic Future of Healthcare, Digital Health Ecosystems. Thanks again to our premium associate partners for their sponsorship of today's session and of our webinar series. Just a few quick reminders before we get things kicked off. The webinar today will be recorded and distributed to members after the event. We will also circulate a survey to gather feedback on this webinar and identify topics that would be beneficial for future webinars. And lastly, we encourage you to type in your questions in the Q&A box throughout the session, and we'll be sure to try and address as many of the questions as possible towards the end of the session. And without further ado, I'm just going to kick us off. I'm going to start with a quick land acknowledgement in light of the tragedies that have occurred over the past number of weeks. We do acknowledge the land that we're meeting on is traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by the Treaty 13 with the Mississaugas of the Credit. With that, I'm thrilled to welcome and have with us today Dr. Anne Snowdon. Dr. Snowdon is a professor of strategy and entrepreneurship at the Odette School of Business at the University of Windsor, and the scientific director and CEO of the Supply Chain Advancement in Health Network of Centers of Excellence. Dr. Snowdon is leading a national research program focused on the capacity of health supply chain to enable health system response to the COVID-19 pandemic in 7 Canadian provinces. This research builds on a well-established program of research focused on healthcare supply chain, digital health, and health system innovation, collectively focused on advancing sustainability of global health systems. Dr. Snowdon has published more than 150 research articles, papers, and cases, and has received over 22 million in research funding. She holds patents and has commercialized a highly successful booster seat product for children traveling in vehicles. We are thrilled to have with us today Dr. Snowdon. I think it'll be a great session. We're going to be talking about how the COVID-19 pandemic is an unprecedented public health emergency that has overwhelmed our health ecosystem, no surprise to us all, and has changed healthcare forever. In this discussion, Dr. Snowdon will lead us in a discussion on how we can leverage this change as an opportunity for better, focusing on enablers such as nimble, robust supply chains, digital health, and data-driven, outcomes-focused future. Again, I'd like to thank our premium associate partners for their ongoing support and for making this webinar and others possible. And without further ado, I'll pass it on to Dr. Anne Snowdon.
Thank you so much, Sandra. It is an absolute pleasure to join you today, and I very much look forward to your questions and the debates and the dialogue as to how do we all collectively move into a post-pandemic future, building on some pretty critical lessons learned. So let me start with where we find ourselves today, talk a little bit about the evidence emerging on this national study across Canada, and where and how health systems really need to consider driving forward to make sure we never find ourselves quite where we are today, hopefully. Never waste a crisis, as many would say. So with that, please go to the first slide. Thank you. So COVID-19, I often stop and reflect. I think all of us, perhaps many of us, remember where we were on 9/11. I think COVID-19 is going to be one of those times where we reflect and look back, hopefully sooner than later. Where were we in this pandemic and how did it unfold for us? It is by far an unprecedented public health emergency, no shock there, but I think where Canada really, really was caught off guard was the unpreparedness. We just didn't have the preparedness, the infrastructure, even the legacy and knowledge that we should have had, having learned from previous events of not at quite this magnitude, but certainly significant around SARS, and I'll speak to that in a moment. The literally overnight shift to virtual care with pretty much virtually no plan and care delivery models in place was a second dramatic change, and one born certainly out of necessity in that early wave when everything closed down. But I don't think we've really critically asked the questions, hey, did that work? What worked and what outcomes did we achieve? By and large, what it really meant is clinicians using telephones and Zoom licenses to connect to their patients, with what I can see so far, no link between those visits and our current data infrastructure systems, certainly none connected to EMRs. No question, all of you would have experienced this firsthand, is an overwhelmed supply chain capacity. There's certainly lots of debate that says, you know, the supply chain didn't fail, it was the manufacturing inability to surge that failed. I think, you know, I'm not sure if that debate helps us move forward, but no question, there's no intent on my part to identify failure on anyone's particularly responsibility. But generally, we just did not have the critical products in hand when and where we needed them as quickly as we needed them. And that's a key point to figure out, how do we do better next time? And the last one, and possibly for me, and maybe this is my, you know, a nurse by training, that is really worrying me personally, and that is the impact of this pandemic and all that unfolded on our workforce. This is probably the very first time, for sure, in the research literature I've spent a long time in supply chain and health systems, that we see the link between supply chain capacity and effectiveness and workforce health, safety, and confidence in their work environment. So we'll come to that in just a moment. Next slide. I think it's also worth reflecting that, you know, this is not the first pandemic this world has, you know, exactly experienced. Many of us would remember the swine flu, the MERS, the SARS, the Ebolas. COVID is a very substantive one, of course, but it builds on a legacy of experience with similar types of events. The million-dollar question is, have Canadian health systems learned from those events? I have to say I'm not sure. But we'll come to some findings and you can make that decision for yourselves, and maybe that's a good point of discussion as well. Next slide. On the other item on certainly on pandemics is, this will not be the last pandemic. It's certainly not the first. So the real question is, in the future post-pandemic world, how are we going to build the legacy of these very tough lessons learned in Canada to date and make sure they never happen again? And I'm not sure we have the dialogue happening in that space either. The other, I think, unique piece of this COVID-19 pandemic has been where and how we have, or perhaps have not, mobilized citizens. And really, essentially, and this is not a criticism at all, but the necessity of that early wave when we really didn't know what this virus was going to look like and how it was unfolding. You know, the massive shutdown, literally shutdown of the entire health system, and the social isolation, and telling and directing populations, communities, people, you can do this, you cannot leave your home, you cannot see your loved ones, etc., etc. I would say it's almost a leadership by compliance. Here are the rules, follow the rules. If you don't follow those rules, you know, here are the penalties. And that perhaps we might really need to reflect on, is that the way we best engage and mobilize our citizens, or do we consider it from not just the compliance perspective, but also the collaboration? What works, what is going to work best for which groups of our populations? If you go to the next slide, this is not a one-size-fits-all. What worked or what didn't work for our parents, our baby boomers in this country, was the virtual care, access to care. Most of the data coming out now, just now, is that the baby boomers don't care for virtual visits. They value their stable relationships with their providers. They'll say to you, look, I need to see him or her eye to eye, and then I know I'm getting what I need to out of my care visit. Where on the other side, our millennials absolutely embraced virtual care delivery and found it exceptionally convenient, so much so that they are now driving towards looking for the provider that's going to continue to offer virtual care and continue with that very convenient access to care. There is also some evidence from a number of centers in Canada that said we were able to connect to and access populations we've struggled to do so. And one clinician shared with me that population of youth and child mental health, particularly from impoverished communities or communities that would be termed vulnerable perhaps, were suddenly able to get to their virtual care visits because it was simply a matter of connecting on a phone or on a Zoom link or computer of some kind. Whereas before, it was only limited to those in-person visits. They would have to take 3 buses, take days off work, which was very, very challenging, get their kids to those appointments, and they frequently just didn't come. So what we've really learned is virtual care has a role. The key question becomes is, for whom does it work best and under what conditions does best look, and how do we tailor our delivery models in those virtual digitally enabled spaces, rather than simply do what we did under tremendous pressure, and that was find digital replacements for care delivery visits that we were so accustomed to. So it's not about digitizing our current health system. It's really about how do we leverage digital tools, technologies to reimagine, personalize, rethink how we're engaging our various populations and fully understanding what they value, what they need in order to work with their provider teams, whether it's the pharmacist in the local grocery store community, or it's the clinician team in the hospital clinic setting. How is it needs to work? Because if it works for the uniqueness and the live circumstances people find themselves, it's more likely to achieve much, much better outcomes. So if you go to the next slide, a couple of comments and thoughts on virtual care, which I've mentioned. The shift was dramatic, and here's, there's always good news and then there's concerning news. The good news is this demonstrated that, health systems can change, and they can change very quickly. We have never as a sector been accused as being agile and flexible and innovative. It tends to take 17 to 25 years, for example, to adopt evidence and virtual tools or technologies or new models of care. We've just figured out and demonstrated it is possible to make a major shift overnight, but of course the events and the incentives contributed to that literal overnight. Here's what the other side of that coin is. What did we not achieve? Did we actually have the time to think through, and how do we now think through what's the impact of that digital care delivery for our workforce? This is an actual picture of a physician at one of the only virtual care delivery centers in North America. It's based at Mercy Health System in St. Louis. He's an intensivist. And this virtual care building, it's about 3 floors, houses all of their intensivist physicians to deliver and manage care and across 7 states and 45 hospitals who have critical care units. So think about his work environment in this picture and compare that to the work environment of our ICUs here in Canada who don't have that virtual. And have we really thought about what are the key features of a quality and work environment that's entirely digital? We are also seeing evidence very quickly emerging now that the workforce is not so sure they're going to continue in their clinician roles. When I speak with a number of the provinces in Canada, but also European systems, US systems, on average, they are experiencing a 20 to 40% resignation rate, particularly in nurses. They are not up for this model of care. They are struggling. They've had enough. And they're not just moving on to other jobs. They're actually leaving the discipline. So it really remains to be seen. And this really speaks to why I'm so concerned about where our sustainability of a health workforce is going to land when this pandemic does eventually settle down. I think we have a lot of work to do in that particular set of questions. If you go to the next slide, just to follow in on the workforce sustainability. This is some data that I think is well worth considering. Again, it talks about the generational differences in our health workforce. This is a study that came out pre-pandemic in 2019 from Blue Cross Blue Shield. It is based on the US workforce, but I think it's at least worth considering how closely does the Canadian workforce potentially represent the same findings. In this data, and it was a very large study, they documented the decline in health in this population at age 27. So what does that mean? A double-digit increases in prevalence of 8 out of the top 10 chronic health conditions in the health workforce. The older millennials have the higher prevalence rates for nearly all 10 of those when you compare them to your Generation X cohorts, cohort to cohort comparisons. Women, this is very much, I think, associated with what we're seeing in our nursing workforce resignation rates. 20% higher prevalence rate of those top 10 conditions compared to their male counterparts. And overall for millennial women, 20% larger adverse health outcomes than men, particularly for major depression, diabetes, and other endocrine disorders. So here we have a health workforce that's not that healthy, and health is declining, beginning at a pretty phenomenal early age, 27. When we compare our current health workforce with their older counterparts, Gen X's and others in this data, it's a substantially higher rate of chronic conditions, chronic illnesses, particularly for women. Given our nursing workforce remains about 80% women, I think we have to be razor sharp focused on the health of our workforce, the impact of our work settings as we now advance and introduce digitally enabled care delivery models. Great, except are we really understanding and seeing and considering what are the key features of a highly quality work environment when it's generally delivering care from a digitally enabled perspective? So a couple things to think about, and you'll see this play out in the research findings in our next slide. We conducted a study, and this was one of the rapid research COVID calls for proposals funded by CIHR, where they were funding teams to examine the impact of COVID, new therapies, vaccines, all of those things wrapped up. We assembled a team, worked with 7 different Canadian provinces. The only reason it was 7 is because they gave us 11 days to write the proposal. Gave us a response within 9 days. That all by itself was a fascinating experience. I've never seen Canadian granting councils fund anybody in less than 6 weeks, but they did. So they've demonstrated a whole new model as well. And we did a deep dive case study on each of these provinces listed on these slides, answering these 4 questions. And what I want to give you today is just a snapshot of those findings. We've published widely on this, and we are about to publish some of the summative findings, but I think you'll start to see where some of these threads are in terms of the impact of supply chain capacity in health systems, and just how critical that supply chain capacity is relative to a health system's performance and ability to tolerate such extraordinary circumstances as this COVID pandemic. If you go to the next slide, we'll start with one of the first and most compelling key areas of findings, and that was the critical role of leadership. We had 7 case studies and absolutely 7, maybe 10 different leadership approaches to managing this pandemic. So the diversity across this country is massive. Some provinces, and I'm sure you can think about which ones those are, and it's not that all that relevant, but some provinces had a very strong and clear and sustained focus on public health leaders leading the management of this pandemic, and the political side and/or the Ministry of Health bureaucratic teams were behind those public health leaders, and they were focused on implementation. When I look across the 7 provinces where that was the leadership model, they tended to have much better outcomes and much earlier successes in both containing COVID transmission and cases, managing testing, and protecting their most vulnerable citizens. Atlantic Bubble, excuse me, is one great example of that. Other provinces who went about a much more political leaders. So when you looked at Ontario and Quebec, you didn't see their public health leader, medical officer of health, nearly as often as you saw their premier. Those are the provinces, and this may not be cause and effect, but just observational. Those are the provinces that had much different types of outcomes. Public health directives, decisions, management teams were vastly different. I would say they could be described as decentralized, and that's where we saw some really very concerning outcomes, especially in those early waves of so many deaths in long-term care. Again, this is not causality here. It is just patterns and themes that we saw across these provinces. Every one of the provinces started in that early phase of the pandemic, first week of March, zeroing in on hospitals first. Of course, we were all socialized by those incredible images from Italy, Spain, devastating images out of New York City as it swept across North America. So all hands on deck, let's make sure hospitals have everything they need. What that essentially meant was community agencies, long-term care, particularly home care, were on their own. And we saw the tremendous chaos that unfolded, not only not having access to critical products, but they don't, in many cases, even have supply chain teams, expertise, or know where and how to find it. So the way the leadership worked, the models of leadership, these emergency operations teams that were defined, how they were led, and from which perspectives, played a role or seemed to be playing a role across the 7 provinces. And when I share that, that's not really just Anne Snowdon's opinion of what I found. What I'm really sharing with you is after about 180 interviews of leaders across these provinces, these were the conclusions these leaders tended to share with us across these different provinces. So I think that's a critical thing to consider. Learning health systems was also absolutely crystal clear. If there was one finding I had virtually in every one of the nearly 200 interviews, it was the realization that we just learned nothing from SARS, because we find ourselves exactly where we were, for those who remember the SARS crisis some number of years ago. Next slide. Inability to manage surge in demand. This one, is sort of a no-brainer. What really was, though, fascinating was this almost immediate response, which I think is an intuitive, response of most people in times of shortages or uncertainty of whether you're going to have products you need. You tend to go into that hoarding mentality. It wasn't just hoarding of individual, and I'm a nurse, boy, I can tell you, nurses are great at finding those supplies and burying them in our little corners or pockets or wherever they are. We just do that to survive, to make sure we can give care to our patients. But many, many provinces shared with me that they had this massive run on masks, gowns, and gloves before the first case was diagnosed in the province, all based on that anticipatory fear that they weren't going to be safe when they went to work the next day if they happened to have a COVID-19 patient in their care. There was a massive increase in product utilization. This data was shared with us by Alberta. 33,000 masks per day are used across the province. It ramped to 760,000 per day in that first wave, and it has by and large stayed almost that same height since that time. Here's the interesting thing, though. Alberta was the only province who could give me an accurate count of what products they were using and how quickly. No other province had accurate digital infrastructure to tell me and to know what products were being used, where, by whom, what supplies they had, what inventory they had on hand. And I'll come to that in a few minutes in terms of how they managed to try and catch up and create some level of estimates on product utilization. But no one had accurate, with the exception of Alberta. Nobody had systematic real-time data that knew what products they had on hand and how quickly they were using it. Many, many provinces' health systems rely on GPOs, shared services organizations. They were struggling just like their system counterparts to respond to the demand surge. And they will share with you, no manufacturer supplier was able to surge in their surge or increase the supplies they had contracted. What they tended to do was say, look, we will guarantee we will supply the products we have with you under contract. We can't do anything more, because of course they could not guarantee they would be able to source or find those manufacturers any more likely than anyone else did. The ultimate outcome of that shortage, though, and that surge, was allocation formulas. Virtually every province and system and organization put in allocation formulas. They were wildly different across provinces, but they would determine at the individual nurse and physician and team level, you are allowed to have X number of masks per day. You can only use an N95 under these clinical conditions. Otherwise, you use this mask, and thus and so forth. Those allocation formulas essentially removed decisions among our health teams on what they could use and how they could use first principles around do no harm and prevent as much as you possibly can any transmission of infection to patients. They removed that decision, and it was purely out of we need to conserve the amount of product we have on hand and make sure we only use it where absolutely necessary. And I'll come back to that shortly. Next slide. Supply chain sourcing, no question. What most health system leaders and politicians, I mean, it's the first time in my life I've seen a US president or a Canadian prime minister use the term supply chain relative to healthcare. So perhaps that's one of the good news, that people now know why it's so important. But the realization that in a single geography is supplying 90% of North American health systems. Mayo Clinic shared with me before the first case in Canada that they knew that they only have enough product to deliver care for approximately 8 weeks. And after that, they had no guarantees that they were going to find the products they needed to find. The other piece that played a role very early and very quickly was what's being called the global me first. These are the country leaders who decided to close borders to distribute critical products. So Trump closed the border to Canada on all N95 masks, pulled them right off runways and out of planes. And we saw the same with vaccines. The US kept all vaccines in their borders to ensure their population did get vaccinated as quickly as possible. So that shifted the global supply chain in healthcare very quickly, increased the urgency, and then really drove everybody, every team, every federal agency, provincial agency, you name it, we're all massively going out to try to find new sources of these critical products. Many provinces, the business community stepped in very quickly, used their networks outside of the health sector to source and find any company that could help them source and find those products like PPE. Domestic manufacturing very quickly retooled and considered a shift towards health products. The catch was any domestic product that hadn't been certified using NIOSH requirements, which is based in Tennessee, was in trouble because NIOSH in Tennessee had no ability to certify any domestic product in Canada. They were only certifying and testing products in the US. So suddenly we had no way to know if a product could get Health Canada approval without that kind of certification. So it was a very big gap. We also had massive amounts of energies put into pandemic stockpiles. When I look across both the provinces and the federal agencies, we have anywhere from 80 to 450 days of inventory and pandemic utilization rates of utilization. So the million-dollar question now becomes, how are we going to coordinate those pandemic stockpiles, avoid what many would say it's going to be we're going to have to throw out a bunch of those products that get expired, and how are we going to work across those jurisdictions in Canada to at least mitigate the risk of that much waste? Waste from an environment perspective, but huge waste in terms of an economic perspective. Next slide. Limited digital infrastructure. This is no surprise. We have absolutely no digital infrastructure that between public health versus health systems versus a health organization, and you all would know this far better than I would, not even sure how much digital connectivity we have between our community pharmacies, our hospitals versus our home care and long-term care, etc. Essentially what that meant was there was no data to inform and track progress. And I wrote a paper that affectionately was called Flying Blind, which is based on the World War II analogy of flying blind, using instruments in those planes only to navigate those flights. We essentially didn't even have the instruments or the data to know whether we were keeping up with the demand for critical products, doing our best to make sure products got to where they were needed most. And we saw that in long-term care. There were not enough products, not even close, and no ability to get hands on those products. in those settings, and the tremendous loss of life is well known to all of us. We had some who said, well, we created, it was like building the bridge as you're driving over it. Some created a tableau strategy like Nova Scotia that became very effective once it was up and running. Ontario's virtual inventory was really a strategy where we had daily counts in the early waves, and then 2-3 times a week counting PPE, reporting it, and then that became the data people would make decisions on. Of course, if there's an urgency or a worry of not having enough, there are very commonly organizations would not report accurately how much they had, because they wanted to be sure they could actually protect their own workforce. Interoperability across health systems, provinces, federal agencies, I could find no evidence that that existed, and it was identified as a real challenge, virtually every one of the 7 provinces. Next slide. Critical product shortages and product data. This goes along with what we've already shared. A number of the provinces tried a number of possibilities in terms of managing allocation models, where you simply assign and make available PPE to clinician teams based on allocation models. What that also meant was they went into every clinical facility, locked up the PPE, and was literally only senior leaders in the organization would open that door and provide or access that PPE inventory to try to control and manage the hoarding. There was no accurate system for identifying alternative products. So what, of course, if you haven't adopted any standards like a GS1 standards to know that this particular glove is what the package information is accurate, it has latex, it doesn't, all those things, that was completely missing. So we ended up procuring products that weren't even usable, some cases counterfeit, because we have no digital system in order to weed out what's a quality product versus which ones are not. Some jurisdictions made the decision to use expired products because they had nothing else. It worked to varying degrees. Others went down the road of reprocessing. Some went down the road of let's use laundry facilities to use cloth gowns because we can't get our hands on the disposal gowns. The reprocessing strategy met with an awful lot of pushback with the professional unions, particularly nurses, who felt that there was no nurse who was going to be willing to use a reprocessed mask and take the chance that it was going to be safe. Next slide, please. The impact on the workforce, and this is probably, as I've mentioned this already, I won't spend a lot of time on it. No question, this is now something that we have to really consider in future forward. Many health leaders shared with me if they were to do this all over again, the decisions we made in those early waves, they would rethink the engagement and the impact on clinical professional workforces. Many clinician leaders said they took the professionalism away from the professional. So nurses, physicians are trained and educated to use principles, evidence to make decisions. Precautionary principles was one of the critical ones in SARS. Again, it was critical in COVID-19. If you don't know the effect and the impact of a virus, you use full precautions in terms of PPE until evidence suggests you don't need them. The reverse was implemented because of those allocation formulas, and it removed the professional autonomy to make decisions. Many physicians, many nurses shared with us, you know, I'm paid to make these decisions. I'm accountable, responsible to make those based on very sound evidence, but that just didn't happen in this pandemic. So there was almost a sense of mistrust that emerged, disillusion, and that may be contributing to what we're seeing in these very high infection rates or resignation rates. It may also be that so many thousands of healthcare workers, last time I looked, over 65,000 healthcare workers in the country were infected with COVID, as many as 40 and over deaths as a result. So all of those things are likely contributing to this future workforce sustainability. I think it's a critical outcome that we haven't seen in other pandemics to this degree that we need to pay attention to. Next slide. So how do we, and I guess I will speed up in the interest of time. These are all the challenges of COVID-19, but let's not forget what system challenges pre-pandemic that are now accelerated, and that is we've got to have a look at this chronic diseases issue. We have high rates and high prevalence of chronic illness. These patients were pretty much left to their own devices during this COVID, And with very limited digital connectivity, apart from those virtual care visits, it remains to be seen what the impact of that is. Similarly, impact of things like shutting down all screening, colonoscopies, mammograms, all those things, and what is the impact going to be on the health system for that missed care delivery that we just couldn't deliver on these circumstances. Next slide. And the other one, of course, is precision. This is a chronic issue that health systems have really need to continue to advance, and this quick illustration gives you a sense of the magnitude. These are the top 10 highest grossing drugs in the US market. Many of them you would know far better than I would know. The red people in the illustration are the relative number of people that improve in those conditions and achieve value from that medication. The blue people are the numbers of people who achieve no value and may experience adverse events. We just don't know what those adverse events are because that's not a digital infrastructure we have in this country. We don't track and trace them. But ask yourself the question, how much money do we spend on these drugs for the outcomes we're achieving for those small groups of people? And until we can track and trace every therapy, every product used in care delivery for every individual patient, to be able to identify who are those red people who should absolutely get that medication because it is going to achieve value, and who are the blue people who will achieve no value. That's until we get to that type of infrastructure and analytics capacity, we are not going to achieve what we need to for some of these chronic illness outcomes. Next slide. So where does that all drive us to in terms of this future health system? Well, with all of those things now looming in our current health systems and all of those substantive challenges, there's no magic bullet here, but at least I think you will agree on some of these key findings. We have to get to a much more digitally enabled health system. Digital health, according to the HIMSS Global Network, is defined as digital health as an infrastructure and ability for our health system to connect and empower people and populations, to help them manage their health and wellness, help them stay well, supported and connected to accessible provider teams working within these very flexible, integrated, interoperable digitally care environments. It's not about digitizing our care delivery to systems of today. It's rethinking our care delivery engagement and how we're engaging people of tomorrow. So I'll quickly walk through what is a digital health ecosystem look like, so that we can stop and have a few questions in just a moment or two. Next slide, please. So a hallmark, the building blocks of digital health ecosystems is really graphic here. It's foundational to have a strong governance and a workforce that's able to deliver digitally enabled care, but in an environment that's got a quality of work life to it. But data stewardship, privacy, security, fundamentally critical. Those became much greater challenges in this pandemic. That's not going to change anytime soon. The second part of this is interoperability. If you can't mobilize, capture data, allow that data to flow to who needs it and democratize it, particularly for patients, then we're not going to advance any number of these challenges that now face our health system. And even if we get that far and interoperability is seamless and we can connect pharmacies to primary care to long-term care to all of these various organizations, unless you apply analytics to transform data into knowledge and insights that supports and informs decisions, both for patients and clinician teams, then we're not going to achieve the value and the personalization we most desperately need to get to. When those things, though, come together, you have digital capacity, and capacity that enables people to know and to set their health goals, that use digital tools of their choice or not. Baby boomers may not be the group that wants to do that, to manage their health wellness, track their progress towards their goals, have the support of clinician teams to help them identify and overcome risks they may actually be facing. And that's when you get to population health and wellness. If you go to the next slide. What are some of those 4 dimensions? Just touch on this. Person enabled. That means it's personalized to the unique life circumstances in every individual. One thing we saw in COVID is inequity. Some patients did exceptionally well, didn't even have a symptom in COVID. Others were profoundly ill or didn't survive. How do we know who's going to be at risk for either of those 2 outcomes? Proactive, does it actually identify what your risks are and help you mitigate those risks? And how are we using digital tools and technologies to understand who are the populations we're delivering care to, who's doing well, who's not doing well, and how do we zero in on those to make sure every person, every citizen has access to best outcomes? Next slide. Digital tools then become those tools to personalize. Analytics, we all use those for almost every other parts of our life. We are teaching online, we use digital tools constantly in travel and banking and retail. This is the moment we've got to start using those same digital tools in healthcare, focusing on outcomes. What are we achieving? What are we not achieving? Rather than following critical pathways and assuming one size fits all. Next slide. How do we do that? One of the key dimensions of that is transitioning from just providing access to care, access to patients, to their own health data, but empowering them and enabling them to manage their care with the support of their teams. Next slide. What does that also mean in terms of data and data-driven decision making? It shifts our health system from react and respond. Wait till you get sick, we'll diagnose this, you'll use clinical pathways and evidence to help you get better, hopefully, or manage your condition. And that shifts to proactive modeling forecasting. Who's at greatest risk for our next wave of COVID? How do we wrap care around that population to make sure they never get COVID and prescribe the various techniques or approaches in order to protect them and to keep them healthy and well? Next slide. That requires an absolutely different type of analytics. It means rethinking value, finding and using data to drive health equity, transparency, build trust in our workforce that they're going to be safe in their work environments, and they're going to have the tools to help every patient do well and achieve the best possible outcomes. And it really tracks what population outcomes are doing well and how do we learn from that and scale best to all other population outcomes, all other population cohorts. Next slide. What does it really mean if it all boils down to, I get this question a lot, so if absolutely every health system in the country adopted and made progress towards a digital health ecosystem, what would we see? We'd see a very robust, very high-performing learning health system driven by data, tracking outcomes, where data is captured, mobilized, analyzed to understand risk, who's at risk, who isn't, how do we prioritize our efforts, our care delivery to mitigate those risks, what new, more personalized care models are needed to achieve value for these unique groups of our patients, and test and make sure they achieve value before we scale it right across the entire health system. It requires a very interoperable, connected data network and one very centrally focused on outcomes, not so much where we've been the last several years is processes. How long did we wait and emerge? How long did it take to get an appointment with primary care? Was a drug available or not? It's very much about what are we achieving, what are we not achieving, how do we learn from that data and make the future health system much more high performing. Next slide. The future health system based on Don Berwick, he wrote this paper in the first wave of the pandemic, and I thought it would be a good place to close. The future health system is not about what will just unfold, meaning fate will not create our new normal, but our choices today will absolutely pave the way to the future. We've demonstrated that speed of learning is possible. It also needs to be faster and more inclusive. Value of standards without question is critical, and we've got to adopt standards in order to reduce variation. So important to protect our workforce. We don't have a health system, quite frankly, unless we have a strong, sustainable workforce that's confident in their work environments. Virtual care, fantastic, but it's not about digitizing home visits. It's about rethinking care delivery and leveraging digital tools to be much more effective in being personalized and tracking outcomes. Preparedness goes without saying, got to get our heads around preparedness. And I would say doing that within each 10 provinces, 3 territories and a federal government, that's got to come to a collaborative platform to do this well. And overcoming inequality. Canadians of all jurisdictions in the world absolutely value every Canadian citizen has access to care, but access to best possible care. And the only way we're going to do that is a digital health ecosystem where that data informs who's achieving best. How do we make sure everyone achieves best? And I believe that's my last slide, and more than happy to get your thoughts, questions, anything that would be helpful to your work in your practices in the pharmacy sector. So thank you so much.
Thank you so much, Dr. Snowdon. This was incredibly valuable and I think so well timed. And thank you for sharing with us such recent and tremendous insights. We do have a few questions, and I'll remind others to enter your questions into the Q&A box, and we'll address them. So, Dr. Snowdon, the first question is, do you see leveraging this new knowledge in healthcare in general outside of COVID, and if so, how?
Okay, let me say that again for me. Do I see leveraging this new knowledge? You mean the research knowledge okay, yeah. Great question. Let me put it to the group. I could use your help. What happens with research evidence like this is you can present it, you can publish it. My experience is it doesn't get everywhere that it needs to. And it happens to be that in the midst of this pandemic, we put a grant, second grant in to say, look, we need a community of practice for all of us, all the various sectors, organizations, teams, to work together to think about what are these findings telling us, and how do we put them to work? How do we apply them and design collectively the future? So we have a group we're proposing, and I would invite absolutely anyone on this call, Neighbourhood Pharmacies, whoever's willing and able to join us, to sit down and really drill down on policy groups. How do we get the provinces and the various federal agencies coming together so we're collaborating on managing pandemic preparedness, or how pharmacies can now be engaged and connected way more effectively to all those other teams, i.e. public health, to be part of the solution, the care delivery models that citizens demand and expect, but we just may not have the infrastructure to do so. So in my mind, it's going to take all of us and then some. But at least if we are all part of the solution, designing the solution, we own that solution, it's more likely to be implemented and scaled. And literally all of us will need to be at the table. So that's an open invitation, and I would be more than thrilled to have you join us on that.
And Dr. Snowdon, you just touched on something that was raised in one of the other questions in terms of how do we overcome those provincial federal divides, and how do we, when we talk about data and healthcare and digital standards, who pays for that? Are there groups and tables discussing this, and how do we, influence that, and how do you leverage the great research you've done to influence that?
Yeah, so many good questions in there. Let me take a shot at some of them. For the first time in my probably 30-year career as a researcher, some of those federal provincial agencies have actually picked up the phone or send an email to say, hey, we want to have this discussion. So, and I think, it's not too surprising. Never waste a crisis. They've all figured out just how disconnected and lack of coordinated we all are. They are rapidly figuring out that price tag. So one very small province in the East shared with me, and they said, Anne, we proposed to improve our supply chain across this province 5 years ago. It would have cost us $15 million to do so. We've already spent $85 million, and I'm only in wave 1 of this pandemic. So if you do the math, I think now there's a realization that that price tag of being ill-prepared is exceptionally high and just unaffordable. So who will pay for it? We all know provinces receive monies, transfer monies from federal. Everyone wants it to be better, but I do see and have been privy to some insights that federal and provinces in various groups, ways and shapes and forms are coming together. They are starting to have that dialogue. Where I think we need to be very mindful is making sure clinicians are in that dialogue, because the last thing we need are decisions at political, provincial, federal levels that are made that clinicians have to live with. We've figured out that doesn't work, and we know it never did work. So I think organizations like Neighbourhood Pharmacies have an incredibly critical role to play to make sure those perspectives are at those tables. And I know I would be more than happy. I'm very, very motivated to make sure that happens as well. So those are just a few of the thoughts I have on that very critical question. But I think it is opening up. It's more open than I've ever seen it. Again, we're still very much in the let's fix it mode. How long will that last? I'm not sure. Memories are short. Our memory from SARS is exceptionally short. I went through the 227 recommendations of the Archie Campbell Commission on SARS. We didn't implement one of them. Had we implemented one of them, we wouldn't have had the outcomes we have today. So don't underestimate the critical importance of learning, but it behooves all of us to make sure we're at that table.
Yeah, I think you raise a really good point. I think the opportunity is now. We're in that let's fix it mode, and it's the onus is on us to be really engaged really quickly before we forget and we move on. But I think you raise a really good point about collaboration. I think between provinces and the federal government, like you said, I think we're seeing governments come together more than we have before to work together, and we're also seeing that within the professional sector as well. We're seeing healthcare providers come together and work together in different sectors, working together a lot more than we have in the past. So, public health and primary care and pharmacies more so than we ever have before. So I guess one of the other questions relates to a lot of your research touches on doctors and nurses, and how do pharmacies fit into this? How does the research, how can that be extrapolated to pharmacies and pharmacists, and what is the role of pharmacies in supporting the progress in advancing digital health?
Yeah, it's such a great question, and I did include physicians, nurses. It was a matter of being able to get to people to include them. But the role of pharmacies is central in terms of connecting people and communities. And far be it for a nurse to tell a group of pharmacists what their role should be. But here's what it occurs to me from my perspective. I did a study about 5 years ago on the role of the pharmacist in grocery stores. And what is that role, and how do consumers see that role? And what was fascinating about that set of findings was citizens go to their pharmacists to double check if the health team got it right. They see them as the trusted advisor. I don't know if pharmacist associations already know this, but for me, that was a fascinating lens on, I'm going to go to my pharmacist. I know him or I know her really well, and she knows me, because they have an ability to connect. They also have an openness because consumers can go to that grocery store, talk to their pharmacist they know so well at their convenience, right? When they feel they need to. That doesn't happen. They don't have that open door in health systems. So for me, that role of pharmacists, particularly those community-based pharmacists, not as much perhaps in the hospital sector, but and that's not a criticism at all, but that is the entry point to a health system for most people in Canada, especially in our rural communities. There are no other options. The pharmacist is the lead of the clinician team. So that connectivity. The other issue that's pretty clear is pharmacies have a massively advanced digital infrastructure compared to virtually any other organization in a health system. So they have the knowledge and the understanding of why standards matter and why you absolutely have to know if that drug is X versus Y, because it matters in terms of outcomes. And that expertise, I think, absolutely must be at that table, because very few groups have that expertise. Nurses don't have it. Physicians definitely don't have it. IT professionals that run information systems don't have any understanding of the clinical side of the house. They just know what data and how it moves. So that it seems to me pharmacists are incredibly well positioned to take that very, very critical role forward to help draw these very disparate lenses and perspectives of clinician, clinical, IT system, patient engagement, working collaboratively with patients to get to outcomes. And it's one of the only groups I can think of that brings that combination of expertise to the table.
I think you make a really good point about the data that pharmacies do have access to. We were some of the earliest adopters of sort of the digital infrastructure, and so we do have access to a huge plethora of data and patient information data, and both publicly funded and private sector data. Right. So I'm wondering, in terms of your research and the integration of health data, do you envision that being, it's kind of a two-part question, do you envision that being just publicly funded, or can the private sector play a role? And then in addition to that, when we look at, the digital infrastructure, are there any barriers today in terms of privacy and legislative barriers for sharing information across industries?
Yeah.
How do we approach this?
Yeah, another group of a bunch of good items. For sure, the private sector has expertise in data and data infrastructure far beyond any publicly system I can see, at least. I mean, I could be wrong, but I haven't found any publicly funded health system that has the digital expertise and systems in place that most of the private sector does. So they have expertise to bring to this table that we just have to get over this public-private thing and get them there, right? At least from what I can see. So that's one part of it. Interoperability is generally that bucket of resourcing and strategies that are needed to achieve this connectivity, more or less, depending on how you define it. And I'm working with the HIMSS Global Network. I actually created an interoperability assessment tool, so organizations and systems could identify how good or bad is our interoperability, so at least you have objective data to know where and how to invest. Interoperability is something every country in the world is identified front and center as a major gap that they are investing in. The bit of my fear is, are we going to invest in the right places? And the only way to know that is when the publicly funded institutional leaders and teams work closely with that industry, because this global supply chain depends on these coming together very, very well and very seamlessly. You can't have a private sector supply chain operating quite nicely that has no line of sight and connectivity to the health system supply chain, which is right now, a bunch of Excel files and reporting how many masks we have. Like it didn't work. So it's the integration and the interoperability between the public-private sector side of the house, which means both must be at that table. And they are investing in interoperability, certainly at the federal level. They got very, very challenged by the PPE, the lack of interoperability on PPE data, which just didn't exist. And then second, vaccines. So two reasons for them why they need to do that.
So maybe, Anne, I'll ask one more.
Sure.
I'll ask it as a rapid fire question, but I know it's a loaded question. So
yes.
I'll ask you for sort of your closing comments. But as we're seeing the economy start to reopen, and you said our memories are short, and we've made so many rapid changes over the past year and a half, and we've advanced in so many ways and invested in so many things that have moved us forward in this space. How do we continue along that path and maintain that momentum rather than reverting back to the way healthcare was delivered before?
Yeah, good question, loaded question, couple of thoughts. Never waste a crisis. It would be an absolute shame if we just threw up our hands and said, well, it's getting better, let's not worry about it anymore. That's what we did after SARS. I was a chief nursing officer. We had the best of intention, and we all see today how far that got us. Number two is it can't just be about opinions. Got to use objective measurement and data and evidence that says, here's where we are, folks, and here's where we need to get to, and we're going to measure our progress over this time frame. I've spent a lot of time primarily because unless you measure it, you can't manage it. We all know that. If a pharmacy doesn't track what drugs it has in stock, how in heaven's name do you have a viable business model? Same thing. We've got to measure where we are today in this digital ecosystem model, framework of any kind, but there's lots of those measures, happy to share them with you. Figure out where we are. What assets and strengths do we have? Pharmacy is a huge asset and strength. Okay, how do we build on it, mobilize it to drive the big gaps we have? Connectivity between public health, hospitals, primary care, long-term care, community care. Just start there. but use objective measures of where we are, where we need to be, and are we progressing? And that, in my experience, has had the greatest impact. Is it hard? Absolutely. Will it take an army of us? Yes. I have been accused of this isn't just innovation, and this is a revolution. Yes, it's a revolution. We need to get there. And I think we have many, many more expectations of the Canadian public demanding we get there. They don't ever want to go through this again. I don't want to go through it again. So the time for me is now.
Wonderful. Thank you so much, Anne. It was a loaded question indeed, but thank you so much for your amazing insights. And we're just over time, so I'll wrap us up now. But just a quick reminder again that this presentation was recorded. It will be distributed to attendees and also posted on our gated member website. Once again, thanks to Dr. Anne Snowdon. Thank you so much for your insights and for sharing your great research with us. And thanks again to our premium associate partners who have sponsored this event. Have a great weekend, everyone.
Thank you so much. Take care.